So good morning. Can I say the honour is mine to be here. It was very strange coming off the airplane yesterday from Ireland, and there was a UFO in the sky. We haven't seen it for a long time in Ireland. There's a big orange disc that exists. I got it very strange. It felt strange this morning waking up with blue skies. Again, something we don't see very much in Ireland. Today we're going to talk about abdominal wall blockade. I feel like I'm on a merry-go-round. It's all I talk about. But hopefully we can understand a little bit more about how important these blocks can be if they're used properly. So we'll get through it. So no disclosures. If anyone wants to give me money, I'm available. Quantas of 10,000 plus would be very helpful. So what were we trying to do with the abdominal wall blocks? I suppose we're trying to look for a gold standard and trying to find something that will replace the epidural. And I don't think we can do it. Okay, from the very start, you have to admit this. You can't beat an epidural. And I think a lot of the studies that are out there, and a lot of the blocks that are out there are trying to replace the epidural, and I don't think it's possible. We have the gold standard, we found the holy grail. And in fact, if anything, I'm talking last night, it seems to be coming back to the CNS, that our movement away from epidural has come full circle, and people are now moving back to the CNS and moving back towards putting opioids into CSF and getting very good analgesic effect. And you'd have to wonder if you can get such good effect with a little bit of morphine in the CSF. Is that not what we should be doing in the first place? So we seem to be on this continual wheel where we're trying to replace this. Please remember, all of the studies that are out there, this is what they're trying to compete with. Level 1 evidence, okay, in randomized controlled trials, not case series, not descriptive series, but level 1 analgesia. Unfortunately, we all know about the side effect profile that's associated with epidurals. They're not that straightforward. They can have complications, and there are some problems. But when you do get gum, which is chewing gum, causing a return of GI function earlier versus epidurals, you have to wonder about the quality of the papers that are being produced in the first place. So where do the abdominal wall blocks come into effect? They come into effect in two main patient populations. First of all are the patient populations in which the epidurals fail. And it does fail, and fails quite frequently because of the changes and difference in anatomy that occur in the natural human being. And they also come into effect when we've got the new drugs that are coming and becoming prevalent in terms of the NOACs, and that we've got a whole patient population in whom we can't go near the CNS because of the potential of causing an epidural hematoma, or because of the fact the anatomy is awkward or difficult, or because a surgeon has been in there before and placed horrible metal in the area. A lot of what I'm going to talk about comes from this paper that we produced mostly with gin. Even though my name is on it, I have to admit that it was gin that did 90% of the work in regional anaesthesia and pain medicine last year. And we really looked at how these blocks work and where they work and how effective they are and how we should be looking at performing these blocks in the future. I want to take a little bit of a step back because I think very often, especially people like me who come to conferences to talk, we talk about how important our block is and how everyone should be focusing purely on our block, and you can forget, not see the trees but just see the wood. There are blocks out there that are extremely simple and extremely effective in the right hands and in the right patient population. This is a block that I love doing and I've gone back to doing. The rectus sheath block. It's an old block. In days gone by, we used a fairly blunt needle. The posterior leaf of the rectus fascia is quite rough and very fibrous. So as you come through the muscle layer, you can actually feel the needle tip grating on the fascial layer and produce a really good block. Obviously nowadays we don't go through the bulk of the muscle, and we have lovely machines that will identify everything for us. But it makes it very simple to perform this block in a huge patient population in whom midline surgery is being performed. All we're looking for is the posterior aspect of the rectus muscle and the fascial sheath around it. And if you inject, as you pass through the muscle into this fascial sheath, you'll get a very good effect. Now you will get a failure in about 20% of cases. in where you get a single dermatome that mightn't be completely blocked because the nerves will come out from the lateral aspect of the linea alba instead of the muscle itself. But it's very, very easy block to do and very, very safe once you stay above the umbilicus, and we'll go through this more in the workshops as how to do it. There are cases now coming through in the publications in the press about this block. We have this, I think it's poison, but we have the liposomal bupivacaine now available, and it's going to happen more and more where patients are putting this, or people are putting this local anaesthetic into planes and fascial planes in order to get prolonged analgesia. And for those who aren't comfortable putting catheters in, it might be something that'll be very, very nice in the future to put it in. But the case series are coming through. The randomised controlled trials haven't really been looked at yet for this population in this block itself. But it definitely is a block that we can use in our patients and use regularly. Okay, and please don't be afraid just because it's a simple block to do, not to do it. Okay. So we're going to go back to the beginning, and we're going to take a bit of a journey through TAP and QL. Okay, because you'll see towards the end how interlinked they are. The TAP block is the main reason that I'm here. I was a registrar in a very small hospital in Ireland. We didn't have an epidural bed, we didn't have a PCA service, and we had a very young girl, 21 years of age, who was coming for debulking for an ovarian CA, and we were stuck. We didn't know how we were going to provide analgesia to this young girl. So we looked at the literature to see what was out there, and there was a very clever anaesthetist from France called Bernard Delance, who's working in Canada or in the States now. He moves around a little bit, and he was using McBurney's point on the anterior abdominal wall to go into the TAP plane in open appendectomies to provide analgesia. So we decided, well, he had block failures because he wasn't posterior enough, so he wasn't getting the lateral branches as they came out in the mid-axillary line, that if we could go posterior to this, that potentially we could provide a little bit of analgesia for this lady. We recognised from the very start that TAP block was a multimodal analgesic technique. It wasn't a standalone technique, it wasn't to replace epidurals, it was just to help us when we did have problems with epidurals or we couldn't provide it. We went back to the anatomy books and we looked at what was available to us, and it was before the time of sonocyte and before the time of ultrasound, and our anatomy and understanding of anatomy was very basic. The dissections we did in college was our reference point, and the anatomy books that we had, the likes of Snell and Netter, were very, very poor in their proper anatomical description of what was going on. And this is the picture that we used initially when we did our publication. We were told that the external, internal and transverse abdominis muscles, before they inserted into the perilumbar fascia, became fascia themselves. We figured with using a blunt needle, if we did a double pop technique through the lateral aspect of the abdominal wall, and we used the lumbar triangle of Petit as our entry point because it was reproducible. If we use a double pop technique, we put local anaesthetic into that TAP plane. The idea was that if we got into the TAP plane, we could block these nerves before they came through to the skin. The nerves came down through the intercostal fascial planes into the abdominal wall to supply the anterior abdominal wall. We figured if we could get in posterior, we could flood the space with local anaesthetic and get a very good analgesic effect, or some analgesic effect. We did it in the young girl. We brought her to theatre, we gave her opioids, we gave her non-steroidals, we went to see her in recovery and she was comfortable. We went to the nurses that night and said, look, she's 21 years of age, she's after having a midline laparotomy from Cipusarum down to pubic symphysis. Please make sure she has enough analgesia overnight. We wrote up morphine 4-hourly PRN. We checked in that night again at 8 o'clock and she seemed to be comfortable. Again, we knew that it was getting close to the third changeover time for the nurses, and then after changeover time you have lunch time, and then you have first break and second break and third break, and we were worried that the patient would fall between the cracks. So we said again and again, please make sure she gets pain relief. The next morning we came in and the patient was gone. First of all, we thought that there was a problem and she'd been transferred to ICU. And then we said, no, she should be in her bed. We went looking for her and we found her 300 metres down the front of the hospital smoking a cigarette. So we were thinking, something's not right here. We went to her, have you any pain? She had no pain. She said, I'm really worried though, because the nurses aren't letting me do my abdominal crunch exercises, so I can't get my figure back from my boyfriend. Overnight, she'd been given 10 milligrams of morphine by the nurses because they said, well, the doctor said you're going to have pain, so we're going to give you the injection. But she had no pain. And our journey from TAP started from there. Now, she was the exception, okay? She got a really good analgesic effect from a very minimal approach. Obviously, at the time I was a registrar, and we went through a number of different publications or ideas for the block. My consultant, Nadeem Rafi, and hence the Rafi, it became Rafi block for a while, regional abdominal field infiltration, wanted to call it the McDonnel block. But I thought, if I called it McDonnell block, I'll never get a job. I'm obviously an arrogant so-and-so, I'll never get a job. Since then, it's obviously gone on to great heights. I put down 400. If you PubMed it now, it's at over 900 papers that are related to the TAP block. I honestly think there's enough research on it. And I don't think there's much more that we can do with it. I think a lot of the papers that are coming out at the moment are pure rubbish, including some of ours. Okay, and I think we need to take a step back and look at what proper science is. When you have one paper producing over 100 blocks per annum in the press, there's something not so right. Okay. That being said, it's great for me because my citation number goes up and I keep getting invited to these conferences, so thanks very much. Okay. But do they work? They really do work, okay? And they work because they're simple. And there's no doubt about it that if you have the right patient with the right block, with the right anaesthetist, then you're going to get a very good effect. If you don't have the right patient, you don't have the right anaesthetist, or you don't put local anaesthetic in the right place, then you're not going to get a TAP block. Okay. Not only do they work, they can actually take on the epidural to a certain extent. This being said, this is published research. If I come to your hospital for laparotomy, I want an epidural. Okay, so don't you go near me with a TAP block. Okay. If I'm on warfarin, give me an epidural. I'll take my risk. Okay. They can approach the analgesic effect of an epidural in the right patient population, but not repetitively, not all the time. Okay. There's a lovely paper by Naraj, and I'm sorry it's very, very small. But what he's saying really is that the block can take on the epidurals if it's done in the right place. And this becomes a real problem, the right place and where you perform your blocks. And in effect, what's happened is that ultrasound really has caused a change in what we call the TAP block. And I'll come to that in a few minutes. Please remember when we did the original TAP blocks, the landmark-based TAP blocks, it was posterior to the mid-axillary line. Okay, and I'm going to come back to that a few times, not just here, but later on in the workshops. And again, you can see another randomized controlled trial. And what it shows that TAP block in the right with the right patient and in the right population can take on an epidural and beat it. Again, I want an epidural if I come to your service. Okay, don't try and do a TAP block on me. I also don't think whatever's been said in press, it doesn't take over or beat an epidural, but it is an extremely safe block to do. So if I do come into you on a NOAC, then this block is something that can be done. Like I said, we were doing really well with all these publications. I had my job secure. I could retire from regional anaesthesia research. I could just concentrate on doing regional anaesthesia, not worry about publications. And then ultrasound came along and ruined my life. Absolutely and utterly destroyed my life. People thought ultrasound was a reason to place needles anywhere in the body, and they did the same thing with the TAP block. And it started coming through the press that they couldn't produce the same analgesic window that we were getting. Remember, we were getting an analgesic window, not an anaesthesia window, from T6, T7 down as far as L1, L2. Okay, we weren't getting reliable anaesthesia, but we were getting reliable analgesia, and I'm going to come to that in a couple of minutes again. And these papers came out, and these letters to the editor came out, and at a few conferences I heard people whisper, and then I heard the whispers that we had falsified our data. And the one thing you don't want to do is upset an Irish person. We're known as the Fighting Irish for a very, very good reason, and it made me really, really angry that people would think that we would falsify our data. We had shared our data before we published it with the idea of increasing patient comfort. We didn't go down this route in the beginning to publish papers. We knew we needed to get a certain number of papers to get our jobs, okay, like we all do. But our main reason for doing the TAP block in the very beginning was not to publish. It was to try and get something that could possibly help patients who couldn't have an epidural. We had no intentions of publication in the beginning, and all the way through, despite the fact that we were trying to publish, we always shared our data with anyone who asked. We gave them our numbers, we gave them our patient details, we gave them all the data that we had. And to hear that we were falsifying our data was very, very upsetting. And it came back to the whole core of the thing, TAP versus RAFI. Okay, and this is where it became a big thing. Like I said in the very beginning, we called the block the RAFI block, Regional Abdominal Field Infiltration. Okay, it changed to the TAP block when I changed hospitals as a registrar. In Ireland, you change your hospital every 6 months to a year. You move from city to city for 6 or 7 years as a trainee. I moved up to Galway and I met Professor John Laffey, who's a genius. And Professor Laffey said, look, John, the RAFI block, nobody knows what it means. It's very, very nice, and it sounds really, really good, and it's very nice of you to recognise Nadeem Rafi. And it was Nadeem Rafi that said we should go through the lumbar triangle of Petit. And that's why I called it the RAFI block. But John said we should change it to something that people can identify with. Where's your local anaesthetic going to? Where's the effect? There was 2 choices. Top block, again, the arrogant thing was going to be a problem. And if we called it a top block, we knew that the English were going to attack us. Okay. The other thing was, where is the local anaesthetic working? And we knew it was working in the TAP plane. And we postulated at that time point that the local anaesthetic was flooding the TAP plane and having its effect by flooding the TAP plane. Okay. So we went to the TAP block. And then ultrasound came along. And our lovely simple picture with 3 fascial planes, lovely lumbar of triangle Petit, all disappeared. And it became a quagmire. And not only that, this is my son. Okay. This is when he was about 3 years of age, so you can see there's a little bit of fat. But my patient population now look nothing like this. Okay, we're not down at 2 centimetres down to my TAP plane. We're down at 7 or 8 centimetres. So the block became a very, very difficult block to perform if you're looking for the lumbar triangle of Petit. Let me just add a little bit of colour so you can see where we are. So if you're looking for the posterior aspect, or sorry, the anterior aspect of the lumbar triangle of Petit, which is the posterior aspect of the external beak, and the anterior portion of the quadratus lumborum muscle, the lumbar triangle of Petit became very, very difficult to see. And what happened is people changed what they were doing to provide a really nice picture, and they moved anterior on the lateral abdominal wall to produce this lovely, lovely picture where you have the 3 muscle layers, external, internal, transversus abdominis. And this is something we can't do anymore. Seemingly now we need ethics approval to stab our residents. Back when we were doing this, it was fantastic. We just bullied them. And we put them into machines and we scanned them. We put them into MRI machines and we gave them a day off. Now I need an ethics approval to do this. But what people did is they moved away from the lumbar triangle of Petit and they moved anterior in the abdominal wall to produce this picture. They brought the needle down and they deposited the local anaesthetic in the TAP plane here. And when they did that, they changed the whole dynamics of the block. The block went from a full abdominal wall in terms of analgesia to an infraumbilical block. Okay, and this is why they said that we lied, that we falsified our data. Okay, because they couldn't reproduce the block that we were getting. Okay, I would say to them, if you get on the bus in Madrid and you aim towards Barcelona and you get on the wrong bus, you're not going to end up in Barcelona. Okay, so in order to provide analgesia, they had to provide a second block, and this is the 4-quadrant TAP block where they went subcostal. Okay. This block was described by Brian O'Donnell in Cork, and Brian was my co-collaborator on the paper, the TAP block papers. And Brian was talking to Dr. Peter Hebert from Australia at a conference down in Cork, and he is very interested in what we were doing. We told him that we were doing the posterior aspect. Our plan was then to move to subcostal because it became logical. If the nerves are coming down into the abdominal field from the subcostal area, then the best thing to do would put your needle in the subcostal area where instead of wasting time for it to come from here all the way around, inject from here back and we'll get the blocks. Peter went back to Australia and published online, using the data that we'd given him, the subcostal approach to the TAP plane. And the problem is, these blocks, I don't know, I found this last night. Does anyone remember Sesame Street? Was it a big thing here in Spain? And one of these kids is not like the other. And it's very like this with the TAP block. That we were performing the posterior TAP block and the subcostal and the mid-axillary line, they're not the same thing. When you look at the subcostal and the mid-axillary line, when you look at where the local anaesthetic goes, it stays in this area. And it's fantastic. And when people started saying that we were falsifying our data, we went back to see where was our local anaesthetic actually going. And this became very interesting because when we did a posterior TAP block, our local anaesthetic kind of went like this as well. But it didn't just stop there. It changed dramatically. And the local anaesthetic, when he did go back into the lab to do a TAP block under ultrasound guidance, ended up in the paravertebral space. Okay. Not only did it end up in the paravertebral space, you can see here it ended up in the epidural space. Can you imagine that? Okay. It also ended up in the vascular system. Okay, so it ended up in the brain as well. So we call it top block, queen of blocks, best block, because it's really a 4-in-1. It's local at the field, it's working in the paravertebral space, it's working in the epidural space, and it's working in the head space. Okay, so really the best block you can ever do. Now, please remember, innervation of the abdominal wall. T6 as far as L1. T6, if I can reach, is here. Not down here, and definitely not here. Okay? And we're going to come to it later on. The most important thing is not this. It's not here at the nerve at the exit. It's actually here. And I'm going to talk about that in a few more minutes. And when people started looking at this, and people started looking at what blocks were working on, where they were working, I'm sorry this doesn't translate very well. When you start seeing where the local anaesthetic was working, what they noticed, again, like I said before, is that when you went posterior, you got a completely different analgesic effect. Not an anaesthetic effect, but an analgesic effect. And a completely different pain effect as well from that. This is John Laffey. John Laffey left us for a few years and went to Canada. Was chief of staff in one of the hospitals in Toronto. And again, he with Ricky Brule and Farah Abdullah, they looked at the blocks and which blocks work, and they said the posterior approach was probably the best way to go. Now, at the same time, we weren't the only people looking at this. There was a number of people that were beginning to look at where the tap block worked and where the local anaesthetic should go. I'm going to mention two people, and I think they've just been absolutely instrumental in the development of regional anaesthesia. So we have two main people that started looking at these things, and the first one was Rafa Blanco. Yes, he's a Spaniard. Okay, there's nothing I can do about that. He says that he's Galician, not Spanish. Okay, I think it's something to do with Barcelona looking for independence. I think the Galicians are looking for independence as well. He said Galicia is the centre of the known universe. Jesus Christ, Galileo, Marco Polo, they all come from La Coruña, according to him. I don't know if it's true. Okay, I'm not going to start an argument. But what Rafa said was, look, John, what people are doing is they're putting their local anaesthetic here. We know when you go posterior with the landmark-based tap block, that the local anaesthetic ends up in the paravertebral space by going around quadratus lumborum and up into the paravertebral space. He said, why not move a little bit more posterior and perform your block there? We said, okay. He did the local anaesthetic injection here, and hey presto, he got a very similar block. Then he just kept moving more and more posterior. Okay, so you have QLB1 and QLB2. At the same time, Jens Borglum was doing something very similar. Now, this is not Jens's paper, this is from Axel Suter. Axel's in the audience. And they were using a posterior approach, or transmuscular approach, and I'm going to come to that in a few minutes. But what they noticed is when you did these blocks at this area, the innervation or the analgesic effect was dramatically different to the midline approach at the level of the axillary, the mid-axillary plane. And they noticed that when you did it like this, the analgesic effect again approached the analgesic effect that we got with the landmark-based tap block. And again, I'm going to come to this later on and probably in the next lecture. We did a single shot technique with no additives, and you get in 24, 48, maybe 72 hours of analgesia. Okay, something not right here. Okay, can I just point one thing out? When we did our original landmark-based tap block, we were coming in at the posterior aspect of quadratus of the external beak into the lumbar triangle petit. We made a big mistake when we did our first tap blocks, and we did our first top block, our first Raffi block, in that we completely misunderstood where our local anaesthetic was going, first of all, and two, where our needle point was ending up. One, a tap block is not a tap block. The tap block is actually a quadratus lumborum block. So from the very start, we made mistakes. But it is very interesting. Again, Rafa went on. He's now working out in Abu Dhabi, and he's performed a tap block, and he's only one of a number of different studies looking at the quadratus lumborum block for different patient populations. It became very interesting then. Jens Borglum, Jens works up in Copenhagen, and Jens is a genius. And they've moved the whole idea of how we should do a quadratus lumborum block on quite a bit. Like I said, originally Jens, well, first of all, Jens was coming from the anterior aspect, but then Jens changed to the posterior aspect, and he used the approach that was initially described by Axel Suter, which is called the shamrock sign, You've got your transverse process, first, which is your stalk, your first leaf, which is the psoas muscle, second leaf is quadratus lumborum, and third leaf is the rectus spinae muscle. And he used this transmuscular approach from the posterior aspect in order to perform the block. And then he subsequently changed it to a different transmuscular approach beside the probe because of depth to it. And the end point for all of these blocks is very, very close. Whether you're here, so in the posterior tap block, the original tap block, the QLB1, QLB2 are transmuscular approaches, and they're very, very simple. But what they have managed to do in the last number of years is confuse everybody. And it's become a spaghetti junction. People are very nervous about where should they place the needle. Okay. Jens, when he did it, first of all, came from the anterior aspect, and he subsequently changed it, like I said, to Axel's approach, coming from the posterior aspect. Again, this is not a QL block. This is actually Axel doing a psoas compartment block. But the approach is very, very similar in that they identified the shamrock sign and then introduced the needle into the plane between quadratus lumborum and the psoas muscle and inject it here. And when they did this, the local anaesthetic ended up again in the paravertebral space. This is not one of their papers, this is one of mine, but it's very similar in terms of where the local anaesthetic ended up. And things moved on, and people moved back from these planes of injection, sorry, just back as far as here, back from this point of injection to realising that local anaesthetic, where, no matter where you put it, it doesn't really matter. Once you're in the same area, it will end up in the paravertebral space. Yes, if you inject it here, it will definitely get up into the paravertebral space a little bit quicker than if you do it posteriorly here or anteriorly here. So the transmuscular approach definitely makes for a quicker onset, but you have to remember what the block is for. The block is for post-operative analgesia, not intraoperative analgesia. It's part of a multimodal analgesic regime. You need to use opioids, you need to use non-steroidals, you need to be using your ketamine, you need to be using all of these different drugs to aid your block. That being said, the local anaesthetic ends up in the paravertebral space. People seem to be afraid to go to the paravertebral space, and I'm going to come to that in a couple of minutes. But people are moving further and further away from our original landmark-based tap blocks, back up towards where they need to go. And KG Chin is probably the main person that's performing these blocks internationally and definitely talking about it, the rectus spinae blocks. And the idea is very simple. You put the local anaesthetic in the region that it works. We know the innervation of the abdominal wall is T6 as far as L1. So the idea is now we're approaching T6 or T7 or T8 and putting our local anaesthetic that little bit closer to the foramina where the nerves exit from the spinal cord. By performing a block, whether you're superficial or deep, it doesn't make any difference. But what Jin did was put local anaesthetic in what he called the rectus spinae plane, underneath the rectus spinae muscle. And surprise, surprise, he got analgesia in patients who are having abdominal surgery. And it definitely is possibly one of the ways of the future, especially for those that are afraid to go a little bit further on in it. It does get analgesia. I don't really believe in it that much for abdominal surgery. I don't get the analgesic effects that other people seem to get with it. Maybe I'm more comfortable with my QL blocks or my epidural or my paravertebral. But it is being used internationally for abdominal surgery. For me, it's a block that I use mostly for spinal surgery, but it's definitely something that's moving towards where we should be. And like I said, there are papers coming out publishing it. My problem with it is that all of these blocks we're needing our local anaesthetic to be transported from the point of insertion to the point of action. In a way, it's kind of like, everyone knows Ryanair, okay, yeah? Okay, I know they're Irish and I'm really, really sorry, okay? It's kind of like, a lot of these blocks are kind of like a Ryanair flight, okay? So you get on your plane in Dublin and you want to go to Paris. And they bring you to Paris, but they don't bring you to Paris proper, they bring you to Paris Beauvais. Which is 80 kilometres away from Paris. And a lot of these blocks are very similar to that, in that you're putting your local anaesthetic into space, you're expecting it to move along these fantastic fascial planes and end up in the point of action. The point of action is in the paravertebral space. And because while they have a field effect peripherally, we know that the effect is only infraumbilical and only localised to that plane unless you extend your block and come to a 4-quadrant. Likewise with the quadratus lumborum blocks and the rectus spinae blocks, the point of insertion is not where you need your local anaesthetic. You need your local anaesthetic to work on the nerve roots. And the nerve roots exist in the paravertebral plane, not in the rectus spinae plane, and not in the quadratus lumborum or the retrolaminar plane. So why not just do a paravertebral block? If that's what's happening and that's where your local anaesthetic needs to be, why not just go and do it? And I suppose we don't do it because we think it's the bad boy, it's the punk rocker of local anaesthetic or blocks that we do. This poor block has been marginalised, and probably correctly, because of the side effect profile associated with this block. Okay, there's a huge problem with it, in that all of these things can go wrong. Now, please disregard this one from the bottom, okay? And it's constantly put down as a side effect profile of the block. And I'm going to really destroy this. Maybe not in this lecture, but unfortunately you've got to listen to me for another few minutes in the next lecture. Pneumothorax. In expert hands, 1 in 250 people that have a paravertebral block will get a pneumothorax. 1 in 250, okay? 1/4 of those will need to be treated. So about 1 in 1,000 chance of having to put a chest drain into a patient. Those numbers come from landmark-based approaches. And they're from people who don't understand anatomy. Okay, they're from people like me who go and try a block and don't go back to the anatomists like Mario and ask, why am I getting a block failure, or why am I getting a side effect profile like this? We all think of anatomy being classical anatomy, that the anatomy we see in our textbooks occurs in 100% of the population. Instead of realising the anatomy we see in our textbooks occurs in about 2 or 3% of our population. Look at the person beside you. Okay, you have about 99.9% of the genetic code of the person that sits beside you, and yet you look nothing like the person sitting beside you. Why do you think your anatomy is going to be the same as the person sitting beside you? In the textbooks, when we talk about paravertebral blocks, spinous process, lamina, transverse process, rib. Okay, we all think that the rib lies right in front of our transverse process. We know by going through anatomy and going through scans, and unfortunately with that horrible ultrasound machine, that when you do a scan of that area, as you move down your thoracic vertebral column, the rib pops above your transverse process in 90% of the population. Okay, the classical approach for a landmark-based paravertebral block is to come 2.5 centimeters lateral from the spinous process, walk down until you find transverse process. Okay, now, if you walk down onto rib and you continue to walk over rib, you're going to end up in the pleura. Okay, and this is what's happening. This is why this poor block has been marginalised. Yeah, sure, it does cause hypotension. Fantastic. Less blood flow, less local anaesthetic leaking from the space, less blood leaking from the surgical site, which is hugely important. Yeah, and we can treat it. We have the drugs. We can do it. It spreads the epidural space. So what? Fantastic. You're going to get a better analgesic effect. You're going to get local anaesthetic where it needs to be. Okay? Yeah, you can get a hematoma. So what? Once it doesn't extend into the epidural space, so what? It's a space. You can evacuate it. Okay? It's going to spread along the lines of least resistance. And believe me, the least resistance is not in towards the epidural space. The least resistance is out into the lungs. And sympathetic block? If I do a block and I don't get a sympathetic block, I consider that a block failure. Okay? So it's fake. Fake, 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 fake. Unfortunately, this man is coming to Ireland. He's going to destroy our lovely green fields. But anyway, we won't talk anymore about it. We have ultrasound. The paravertebral block is now an easy block to do. It's a block that I teach my first and second year residents to do. It's not something that we leave for the experts anymore. We look for certain structures. We look for a rib, nice and round. We look for a transverse process, lovely and flat. We look for the pleura in between the two, and we can't see them, but we'll show you later on how to do it. And then we imagine where the intercostal or the costotransverse ligaments are, and we put a needle down into them and we do a block. They're not difficult. Now, please remember, when we're doing these blocks in our workshops, we all cheat. Okay, because we have really thin models, or they've got people from Spain. Okay, you don't have Irish models who are a little bit larger. We sit our patients up so all the fat falls down. Okay, but in the workshops, hopefully, we'll get through how to do these blocks properly. And what you want to do is you want to block your sympathetics. Please remember the picture where we talked about the spread of our local anaesthetic from the TAP block, QL block, rectus spinae block in towards the paravertebral space, and the local anaesthetic spreading along the lateral border of the vertebral body. And I said this is important. It's hugely important because the sensory afferents they're nice to block. Okay, and if you look back at our original studies, remember we talked about when you get people like me on a stage like this, who get to stay in really nice hotels and get really nice free meals, free flights, get to sit by the pool when they're not working. Mario, sit by the pool. Okay. All right, but unfortunately Mario works us too hard. When you do a block like this, when you do a paravertebral block, it's the spread to the epidural space, or sorry, to the sympathetic block that's important. We've forgotten where our blocks work and how our blocks work. We're trying to get sensory afferents. When we did our first papers, when we published our papers, if you look back at a paper 800 papers ago, you'll notice that we never talked about the paresthesia level that we got in our patient population. We got a paresthesia level, we just didn't present it. We didn't have to. And this is the problem with publishing papers. You don't have to present all the data that you have. You only have to present the data that's nice to present, to push the agenda that you have. When we did the original TAP blocks, and when Jens and Rafa Blanco did their QL blocks, and when Jin does his rectus spinae block, they don't talk about their paresthesia window. They talk about their analgesia window. When we did the TAP blocks, we got a very strange phenomenon. We got analgesia from T6, T7, and occasionally up as far as T4, down as far as L1, L2. But the paresthesia that we encountered was very, very different. We got levels that were blocked in terms of analgesia, but perfect sensation. Okay? So that doesn't compute with us blocking sensory afferents. That computes with us blocking something else. And that we're going to finish. So let's finish off in conclusion. Decide where you want your local anaesthetic to work. Okay? If you're getting on a plane in Spain and you want to go to Ireland, which is a very, very good recommendation, you don't need to stop in Belgium, France, Germany, and England on the way. Put your local anaesthetic where it needs to work. For me, the development of the TAP block was the QL block. The QL block went to rectus spinae block, and rectus spinae block went back to where it should have been in doing the paravertebral block. If I come to your hospital service and I'm having abdominal surgery, epidurals are nice, paravertebrals are better. Okay, it's the king of blocks because it's the one block you get consistent analgesia with. Okay, the reason the epidural's block fails is that you don't get high enough. You're not blocking all the sensory or the sympathetic fibres that insert above your epidural level. Okay, remember the patient you have on the table. Not all patients are going to be amenable to an epidural. Likewise, not all patients are going to be amenable to a TAP or a QL block because of their size. But potentially you could do a rectus sheath block in these patients. Okay? You might be able to get the surgeon to do the block. Okay? It's a big change in concept. The surgeons are in the abdominal wall, they're up beside the diaphragm. They can definitely do a QL, an anterior QL block at that level. For me it's very hard because I'm a very arrogant person and I'm afraid of giving anything away to anyone else, and definitely not giving the surgeons more power. But you got to at times think about the patient that you have. Do the right block for your skill levels. Okay, these are simple blocks. We should all be doing them. Ultrasound has made everybody an expert. Okay, do the block that your skill level's at and try and progress to the next level. As you get patients in, use them to scan. You're not doing any harm by scanning, and you might be doing some good in the future by using those technique skills that you have. And like I said, use the technology that's available. We have ultrasound. Like I said in the beginning, I hate it. Now I sleep with it. I absolutely love my ultrasound machines, and they're there and they're everywhere. That being said, not all countries will have them and not all cities and centres will have them, so don't forget to practice your skill levels. Thank you very much.
Do you have any questions? Yeah, another lecture from...
Go to www.ultradissection.com or info@ultradissection.com.